Hello, I'm Dr. Chandrani, obstetrician and gynecologist in Neotia, Bhagirathi Women and Childcare Center, Newtown. And today, welcome to Inside the Womb. With me, joining fetal medicine specialist Dr. Sumana Haque. Hi, Sumana.
Hello, glad to be here.
Thank you. So, let's start with the basics. Please tell me, Sumana, what are chromosomal abnormalities?
So, the chromosomes are thread-like structure that contain the genetic information of our body. We inherit 23 pairs, each from our parents, and any alteration in the structure of the chromosome, a deletion of the chromosome, or an addition of a chromosome may lead to chromosomal abnormalities.
Okay. So, now we are going to discuss about the prenatal diagnosis of chromosomal abnormalities. So, before we come to the details of the discussion, just let me clarify, or you just tell me, because when the patient comes, they presume, when we ask them to go for this prenatal testing, they presume that all the tests are diagnostic. So, can you please clarify the difference between the diagnostic and screening tests?
So, the screening test is something which we use to assess whether a baby has a possibility to have a chromosomal abnormality, whereas the diagnostic tests give us a confirmed answer whether this baby will have a chromosomal abnormalities or not. So, when a pregnant patient comes to you for the first time, how do you counsel the patient regarding chromosomal abnormalities?
So, precisely saying it's not the first time, but it's the second time. The first time when a patient comes, she comes with the booking sonogram to confirm a pregnancy, a live pregnancy with a heartbeat. Then when she comes with that ultrasound, I counsel them regarding the prenatal testing. So, the first test we suggest is the combined screening. Combined screening means there is a scan which we call NT scan, which is a nuchal translucency scan, where we see the fluid level behind the baby's neck. There is a certain cutoff beyond which the risk of chromosomal abnormality increases. And along with the scan, we do a blood test, which is called a double marker test.
So, can you tell me which weeks do we suggest this?
Yeah, I'm coming to that. So, in double marker test, we do beta HCG and PAPA. So, I counsel the patient, first of all, this is a universal screening. This is for everyone, irrespective of your family history, irrespective of your age. You should go through this screening, and this is a very time-bound test. You should do it between 11 to 13 weeks, 6 days, and it has a very good detection rate, almost 90%. But we definitely tell them that, as you told us, that it is not a definitive testing, it's not a diagnostic test, it's a screening test.
So, by chance, if the patient misses this test, as you said, the window period is very small,
Yes.
11 to 13
Yes.
weeks, 6 days. So, if the patient misses the test, then and she comes later on to you, say around 14, 15 weeks, if
Yes.
she comes to you,
Yeah.
then what do you do?
So, it's a very common thing, patient misses this test or comes late or books late. Then we ask them, you can go for quadruple screening, quadruple marker and genetic sonogram, but that is also time bound, because the quadruple marker is done between 16 weeks to 22 weeks. But here we also tell them, since you have missed the FTS, you have missed the combined screening, the detection rate is slightly lower. The quadruple marker, the detection rate is almost 75%, not more than that. Now, Sumana, can you please tell me a few details about this genetic sonogram?
Okay, so genetic sonogram is basically done in the second trimester. Here we assess structural findings and any other soft markers which are associated with chromosomal abnormalities. So if these findings are there, the possibility of the fetus having a chromosomal abnormality increases, and we guide the patient accordingly.
So just let us discuss how we interpret those results, because we have asked them to go through the tests, but they should know that when the result comes, how to interpret them.
Yes. So when the patient comes to you with the result, so how do you interpret as an obstetrician when,
Yes.
sometimes the patient don't come back to the fetal medicine specialist, they go directly to their obstetrician, the primary referring consultant.
Yeah.
So how do you guide the patient?
So when the patient comes with the results, the combined screening test, so the result comes as low risk, intermediate risk or high risk. If the results come as low risk, I reassure the patient that 90% chance in this pregnancy, there is no such genetic problem which we have screened. If the result comes as intermediate risk, there is a test called NIPT we might offer, and I definitely send them to you, the fetal medicine specialist, for further discussion. And if it comes as high risk, then we definitely send them for invasive testing or the needle test. Now, Shumana, just please elaborate about the pros and cons of NIPT, and we'll come to the invasive test later.
Okay, so the pros of NIPT is that it is non-invasive. So there is no chance of miscarriage which we face in case of invasive testing. So the detection rate for Down syndrome in case of NIPT is very good. It is around 99%. In case of trisomy 13 and trisomy 18 also, it is fairly good. And the results come pretty early, that is around 1 to 2 weeks time we get the results. The cons are that the test does not give us a confirmed answer. That is, even if the test is positive, we have to confirm it with an invasive test. In some cases, we might not get any result. This test is costly. So if many patients may not be able to afford this test.
So there we came with the intermediate risk result. Now when a patient comes with high risk result, we ask them to go for invasive testing, that is the needle testing. So let's talk about the needle testing or the invasive testing, because as it is an invasive one, the patients are frightened when they hear about the invasive testing, because they are already very depressed as the screening test came as high risk. Now we are offering them, you go get a needle test done, something will pierce them. So we should clear the anxiety about the needle test, and let's talk about the needle test now.
So I understand the patients are very anxious, and it is our duty to guide them properly. So what I do is that I tell them about the risk and benefit of an invasive test. So in modern day practice, the risk of miscarriage with an invasive test is very less, that is 1 in 1,000 when done by expert hands. So the patients can go ahead with the invasive test if the risks are very high and there are certain findings, like the findings in case, if we have multiple soft markers, if there are certain definitive marker, if there is an absent nasal bone, if the NT is more than 3.5 in during FTS, in case of second trimester findings, that is if there is an aberrant right subclavian artery, if there is an increased buccal fold thickness, if there is a ventriculomegaly, and or if the parents are carriers of certain genetic diseases, like in case of thalassemia. So in these cases, we have to go for an invasive test. I tell them the risk and the benefits, and then I ask the parents to decide accordingly. So they can, opt out for the invasive test. Whatever they be their decision, we have to respect them, and we have to go accordingly.
Also, in a few cases, like we recently did, if the parents have already a child who having some genetic problem, like the parents already had a child who had a Down syndrome, here we directly offer them an invasive testing. We tell them there are two types, like we can take a portion of the placenta or the fluid to be decided by the fetal medicine specialist. And we also test them, although the risk of miscarriage is very, very small in expert hand, but it is technically still there. And there are few things after the testing, we offered them some medicine and all. The test takes some times. Then,
so invasive testing can be done by two ways.
Yeah.
It is the chorionic villus sampling, in which we do the placental biopsy. This can be typically done between 11 weeks to 13 weeks, 6 days. We extract a portion of the placenta, we extract the fetal DNA from it, and we send it to the lab. The lab in turn gives us a confirmed diagnosis whether this baby has a chromosomal abnormality or not. In case of amniocentesis, we extract the fluid in which the baby floats. This is typically done after 16 weeks. And in the fluid, this fluid is taken by the needle, as she has discussed. Yes. By the ultrasound guidance. So we insert the needle into the maternal tummy by the ultrasound guidance, and then we extract this fluid. This is sent to the lab. From the lab, the DNA, the fetal DNA which floats in the fluid, is extracted. And just like CVS, this gives a confirmed answer whether the said genetic abnormality is present in the baby or not.
So the take-home message should be, we're nearing the end of the discussion. The take-home message should be, you should never miss the obstetrician appointment. because especially the first trimester and the early second trimester, that is the first 20 weeks, this is the time when all the problems in the baby are likely to be diagnosed, the structural problem, the genetic problem, and the scan should best be guided by a fetal medicine specialist. And few things we would highlight, we have already told in the discussion, but the few things we need to highlight is that screening tests are not diagnostic, and whatever your background family history and whatever your age, because there are many patients who think we are young, why should we have a baby who has a genetic problem, or we never had anyone in our family who has a genetic problem, then why should we go through the test? The tests are costly, the tests are new. So whatever the background, you should opt for the universal genetic screening. Thank you.
As doctors, as specialists, it is our duty not only to diagnose chromosomal abnormalities, but also to provide clarity and empathy and respect the values of the patients. So I hope you like the session, and in case you have any queries, then you can get back to us in the comment box below. Thank you so much.